So what all things will we cover in this class? First thing is what is the need for topo guided PRK followed by CXL? What is the inclusion criteria, exclusion criteria? Why are we doing topo guided PRK? Is it only for the surface regularization or are we also including a spherocylindrical treatment in it? What about the status of mitomycin C post PRK? Then we will compare the CXL duration and fluence used in various studies, their outcomes, and also have a quick word on whether to do it in the same sitting or CXL followed by 6 months later PRK. So after studying around 20 to 30 papers, there were a few common indications which I came across. This topo guided PRK immediately followed by CXL is usually done in cases of progressive keratoconus. Progressive keratoconus, the definitions have varied across studies. Progressive keratoconus patients who need CXL, in whom the best corrected spectacle vision is poor and the patient is contact lens intolerant. So with the topo guided PRK, we are targeting the corneal curvature, irregularity, aberrations, astigmatism, and residual refractive error. And with the CXL, we are aiming to halt the progression and have a biomechanical strengthening of the cornea. So what is the inclusion criteria included in various studies? So various studies have defined progressive as a change of 0.75 or 1 diopter change in the corneal curvature over a short period of 3 months, 6 months, or 12 months. Some studies have also included a decrease in the corneal thickness of around 5 to 10% or more at thinnest point over 6 months or 12 months. Most of the studies have included only mild to moderate grades of keratoconus with a minimum age of 17 years, and the patient has a intolerance to hard contact lens and full spectacle correction intolerance. Most important point to note is that the expected central corneal thickness after PRK in all of the studies is at least 400 microns, and no other corneal pathological signs like scarring is included in the studies. So if we go by the ABCD criteria or the Amsler-Krummeich criteria of keratoconus, we can only include up to stage 2. What about the exclusion criteria? Most of them have excluded any systemic autoimmune diseases, previous eye surgery, chemical injuries, delayed epithelial healing, pregnancy or lactation because that causes change in fluctuation of the keratoconus, and corneal scarring.
Okay,
For
Pranav,
the
here I have a question for you.
Yes, sir.
I have a question for you. You've nicely told us about the indications, and the first line was that progressive keratoconus needing cross-linking, right?
Yes,
So
sir.
that's good. I mean, that's what we normally do, and all our patients have been like that. While you were speaking, a question came up, and that's open to discussion. Why? What about a patient who has stable keratoconus? Okay, but he has a very irregular cornea, which is causing him discomfort, poor quality of vision, is contact lens intolerant. Okay, and meets the all the other criterias for your this thing. Would you be comfortable doing a PRK, topo guided PRK, to regularize his cornea and cross link it, even though
Uh,
the keratoconus is already stable and cross linking may not otherwise be required?
Yes, sir, I would go for it because long-term follow-up of these studies have shown that there is minimal progression, and most of the studies have shown that the loss of lines in vision or haze or endothelial loss in long-term follow-up studies of at least up to 3 years have been minimal. So if the patient is still stable and meets the other criteria, especially about the corneal thickness, then we can potentially go for a PRK followed by CXL.
Are there any studies which have reported on this?
No, sir, I mean prophylactically nobody has done. They're
No,
in
no, not
everyone.
prophylactically. No,
I
no, no.
mean, no,
It's not
no, they have
prophylactic.
not included stable keratoconus patients.
I think you should look for it.
Sure, sir, I will look for these
If you do a
studies.
literature search, you might just specifically, if you look for this, you might find some case reports or something or some study. Just see if there is anything reported.
Yes, sir. Yes, sir.
Dr. Ruchika, what are your thoughts on this? I mean, would you think about doing this for a patient who came with poor quality of vision, contact lens intolerance, and an eye which looks like it is going to improve significantly with a topo guided ablation of 40, 50 microns and cross-linking it.
So, sir, this is similar to what they used to do earlier. Like, I mean, earlier they used to do cross-linking, wait for 6 months to a year, and then do a PRK. This is almost a similar situation.
Mm-hmm.
So, I think it is. I
Would it be
mean,
better to approach it like that, like cross-link it first? But see, why would you cross-link it first? Because the keratoconus is already stable. And
no,
if you
sir.
cross-link it
Like,
first and then ablate it,
no. What I mean is that. Okay, so you're saying a cornea which is not cross-linked but is stable naturally.
yes, yes, yes.
Oh, okay.
It's a very difficult question to answer, actually. I mean, would we want to touch with the laser a cornea which is keratoconic but stable? Because hypothetic, I mean, we are actually inducing weakening of the cornea, which is already otherwise stabilized but has poor quality of vision because of irregular astigmatism and maybe decentering of the apex and everything, and potentially treatable, a good candidate for a topo guided ablation to regularize the cornea. Would we be comfortable doing a topo guided ablation and then cross linking it just for the sake of improving the quality of vision?
So then in that case, I would probably look at other approaches of regularizing the cornea, maybe intacs or something else. I mean,
Mm,
I PRK probably wouldn't be my first choice in this case.
mm,
I
mm,
would look
mm.
at other options or ways of regularizing the cornea.
Good thought. I think Intax would be a very, very good option because there you are strengthening, not weakening the cornea, right? I mean, not strengthening, but at least you're not weakening it by doing something counterintuitive.
Or even
Perfect.
now
Let's.
we have cares and other
I think we should
like
seriously be considering to do cares because now there are a lot of people reporting, and I'm really surprised. I used to dismiss it as being irrelevant, but with the way that the people are reporting, I'm still skeptical. But I think we should definitely do a trial.
right.
चलो ठीक है. So let's go ahead.
So what all pre-op parameters have been assessed are autoref, auto-K, corneal topography and tomography, mainly the thinnest pachymetry, keratometry values, cone dimensions, and anterior and posterior astigmatism as well as elevation. The uncorrected visual acuity, best corrected spectacle visual acuity, manifest and cycloplegic refraction. The SAG factor, the SAG factor also has been studied in a study coming out of SN. They have defined the SAG factor as the maximum dioptric difference between the peak of the cone and a point which is equidistant and equiangular as the peak was from the center of the cornea. So it should be on the same radius, but it should be equidistant from the center of the cornea. So we are just comparing diametrically opposite points, and that is known as a SAG factor. Many studies have also included keratoconus parameters like index of surface variance and index of height decentration, as well as aberrations in their studies. So coming to why do we do a topo guided PRK in the first place? So the idea is that it is a fitting of an ideal corneal shape, which is usually a sphere, but it's an aspheric surface to be precise, under the present topography map with the ablation of the tissue in between. So there has been one hypothesis which has said that it can be technically used in scarred corneas as topo guided treatment is dependent only on the surface. So this can be a point of debate because topo guided treatment is only considering the anterior surface of the cornea, and if the patient say has got hydrops, so he has DM scarring elsewhere, not in the visual axis, maybe potentially we can go for a topo guided PRK. Uh, so the mechanism of topo guided PRK is that it flattens the cone peak. Also, it flattens an arcuate broader area of the cornea away from the cone, usually in the superior nasal periphery, because most commonly, especially in the Indian population, we have seen that the cone is inferotemporal. So this kind of resembles part of a hyperopic LASIK kind of a treatment. Thus, this will cause some amount of steepening or elevation adjacent to the cone, effectively normalizing the cornea. And it has been said that this new flat cornea and less irregular cornea performs better biomechanically. So not only is it better in terms of visual acuity, topo guided PRK in itself, without the CXL part, will help regularize the cornea and flatten the cornea and perform better biomechanically because the cornea gives away at the area of the cone. And after topo-guided PRK, we have a flatter and a broader cone, which may redistribute the biomechanical strain from the eyes in IOP as well as eye rubbing. So this flattening effect and the safety is further enhanced with a CXL adjunct. So the PRK that we are doing, does it have to be only topo guided? A study conducted by Amri et al. Has shown that non-topo guided PRK followed by CXL also has worked well. But I could not find any studies comparing non-topo guided PRK versus topo guided PRK followed by CXL for the same. So even if somebody does not have Contura, they can still do a normal wavefront optimized PRK and get good results. So
So Pranav, it won't be, what you're saying is right, but it won't work for all keratoconic corneas, you would have to do very, very significant case selection. I have done, when we did not have topo guided PRK 15, 20 years back, I have done for a few patients, but they were not asymmetric cones. They were basically symmetric central keratoconus where it worked. Okay. Otherwise,
Understood.
if you're just doing a wavefront guided, kind of a wavefront optimized treatment on a irregular cornea, which is totally aberrated, it won't make any difference to the patient because then you're not treating the astigmatism. You're just treating, unless you have some kind of a treatable astigmatism which mimics a bow tie, and you're trying to decrease that with some kind of and where the keratometric values are matching the manifest values, okay,
Yes,
for
sir.
astigmatism. There it might help. Otherwise, it won't help at all. All right. So this has
Okay.
to be a very qualified statement when you say that.
Okay, sir. Okay.
Okay.
So coming to the PRK part of the surgery, so the topolaser data is imported onto the examiner platform and we can adjust the sphere, cylinder, axis, Q value, optical zone and treatment zone. So removal of the epithelium can be mechanically with a brush or alcohol assisted removal, which was done in the originally described Athens protocol, or it can be done by the examiner laser itself using the PTK mode, that is the trans PRK, which is known as the Cretan Plus protocol. I'll be explaining these later on. So to ensure minimal tissue removal, the effective optical zone in this PRK is kept at only 5.5 mm versus the normal 6.5 mm zone which we keep in refractive surgeries for PRK. The transition zone is 1.5 mm. So the grassly epithelium gets debrided to an extent of 8.5 to 9 mm. And for CXL, if we need further debridement of the epithelium, then the rest of the epithelium in the periphery can be removed mechanically. The important point to be noted here is that the maximum ablation depth across all studies after epithelium removal was capped at a arbitrary value of 50 microns, which started from the first paper, I mean the first case report which was published on Athens protocol. They have said that depth of 50 microns ablation, and all the further studies and papers have stuck to that 50 micron maximum depth of ablation. Uh, Subsequent studies have also included a spherocylindrical correction, and they have limited it up to 70% treatment of the cylinder. So treatment of the cyl took priority over the sphere, and other studies have tried correction up to 40 to 50% of the refractive error, depending on how thick the cornea is preoperatively. So coming to the method of epithelium removal, which is the Cretan protocol, which is also known as the PTK or the phototherapeutic keratectomy.
Pranav, can I
Yes, ma'am.
stop you for a second?
Yes, ma'am.
Yeah, so the astigmatism which was treated was based on what was the measured axis and measured astigmatism, or what was the acceptance of the patient or the
Ma'am,
manifest.
they have not described in great detail as to which axis or the magnitude, what magnitude they have treated. In all across all studies, they have
Magnitude
not.
anyways was 75% of whatever was the,
Hmm.
but was it the measured magnitude or the manifest magnitude?
Ma'am, these details are not there in the papers, ma'am. They have not mentioned it. They have just mentioned up to what percentage they have ablated.
But
Because
Pranav,
that is the
it'll be very easy to say if you find that they were doing topo guided PRK, then it would be 70% of the topographic astigmatism. Whereas if they were doing just standard PRK, then it would be 70% of manifest. What I understand is when you are saying this 70%, this is of the manifest astigmatism. not of the topo guided type. So these papers must be all on standard PRK for keratoconus and not on topo guided PRK is my understanding. Because I used to do this and I was doing this 70% of the astigmatism for my patients when we did not have topo guided PRK available to us. But you should cross check it and you see whether those studies which are
Hmm.
quoting 70% are doing a topo guided PRK or a standard wavefront optimized PRK. Okay.
No, sir. All of them are topo guided only. Only one or two papers are non-topo guided PRK. The one which I mentioned, only that
Okay.
one is normal non-topo guided PRK. Otherwise, all the papers starting from the first case report are for topo guided only.
See, the thing is that when you do topo guided, many times you don't even feed any astigmatism, you feed zero.
Hmm.
You understand? You are only trying to treat the
Yes, sir.
aberrations. So there you might actually not feed the refractive error at all. So it may
Yes,
not be
sir.
70%, it may be zero astigmatism that you're treating. Because all
Hmm.
you're doing is regularizing the cornea and not trying to treat any manifest refraction. And sometimes when you're trying to treat manifest refraction part of it, it may not be 70% at all. It may be much smaller. So I am skeptical about the fact whether, these were the studies which have quoted like treating sphere completely and 70% of cylinder. They are very unlikely to be topo guided. That's my thought, but we can cross check.
Yes, sir.
Okay. Also, I
So,
wanted to ask you,
yes,
like
sir.
you were talking about doing the that the shape regularization achieved by the topo guided PRK, the cone flattens out a little bit, and the periphery you are kind of also doing some peripheral ablation to steepen the area which was flat, right? So while that is all right, because in the periphery you have adequate thickness, but on the cone you have a very thin cone, right? And you are ablating maybe 20-30 microns of that cone and leading to more thinning, right?
Yes, sir.
So even though you are cross-linking it, but isn't that counterintuitive? Like, you are actually thinning the cornea from the weakest point.
Yes, sir. That's why the thinnest package they have taken 400 microns. So that they have judged as to be the adequate thickness to be touched. I mean, the threshold to touch the cornea that they have mentioned is the thinnest package should be at least 400 microns after the PRK. So before the PRK, it should fairly be around 450, 460
Hmm.
microns.
ठीक है. So would you be comfortable removing 50 microns, which is your maximum ablation from the cone?
Uh, so yes, sir. If it fits well into the pachymetry, then yes, sir.
ठीक है, let's go on.
Uh, so coming to the Cretan protocol, so the topolizer detects the anterior corneal surface and the epithelium tries to mask the stromal irregularity as we know. So hence the surface may appear fairly uniform preoperatively. So the epithelium over the cone is thin and over other areas there can be compensatory thickening. So if we remove the epithelium mechanically or on based on with alcohol, it exposes the underlying stromal irregularity, which may not be picked up, which may have not been picked up by the topolizer preoperatively. Hence, there may be a mismatch between what the topolizer planning is and the actual surface that we get after mechanical or alcohol assisted epithelium removal. Hence, studies have shown that PTK removal of the epithelium is preferred. Also, it has been said that it is less invasive than the more traditional surface ablation and it shortens the reepithelialization time. So, I'm going to explain why PTK removal of the epithelium is better. So, what is the rationale and indication of using PTK? So, there is an epithelial donut pattern in keratogenic corneas, which is characterized by localized central thinning surrounded by an annulus of thickened epithelium. And due to this epithelial donut pattern, the TPTK in Cretan protocol uses the patient's own epithelium as a masking agent and it facilitates the removal of small quantity of anterior stromal tissue on the cone apex along with the epithelium. Hence, it has been seen that the PTK during CXL additionally targets to smoothen the irregular anterior corneal stroma. It decreases the corneal astigmatism and it also enhances the postoperative outcome. So the Cretan protocol, it has been said that it can be performed in any case of CXL, even in those in which combined PRK CXL procedure could not be an option due to low corneal thickness. So essentially what they are saying is that if somebody who is not fitting into the corneal thickness uh, restraints that we have for a topo guided PRK plus CXL, if we are doing a CXL for some patient with progressive keratoconus, we anyway have to remove their epithelium and do the CXL. So during that removal of epithelium, we should rather choose a PTK mode to remove the epithelium in order to shave off some of the anterior bulging stroma at the cone level, which is going to help us regularize the surface and have some effect on the refraction as well, and then subsequently perform the CXL. So that has been shown by the Cretan protocol. So after doing the PRK, the ablation, what is the status of using mitomycin C? So a cellular sponge soaked in mitomycin C 0.02% is applied over the ablated tissue for 20 to 30 seconds, followed by irrigation with 10 ml of chilled BSS. So there are a few studies which have used MMC and there are a few studies which have not used MMC, and all of them have had good results. So there is no differentiation in between them. But one school of thought is that the use of MMC is considered unnecessary because the CXL itself has a depopulation effect on the corneal keratocytes in the anterior stroma. So after PRK, the keratocytes are getting activated and that is causing the post-op PRK haze. But since after PRK we are doing the CXL, which in itself is going to dip, delete, have a deleterious effect on the keratocytes, the risk of having a post-PRK haze is lesser. So the role of mitomycin C is considered as a point to debate in this. And subsequently, it has been known that the additional effect of MMC on keratocytes is unnecessary and it has an unknown possible implications in the stromal repopulation of keratocytes, especially in the combined procedure. So after the PRK and the MMC, we come to the CXL part. So most of the studies have used the 0.1% solution of riboflavin, which is isotonic. A few studies have used dextran solution. A few studies have used the dextran-free HPMC solution. The duration of soakage is in few studies around 10 minutes and in a few studies is around 20 minutes. Uh, this is as compared to the traditional protocols where we soak the cornea for 30 minutes. Here they have hypothesized that since because we have already done the PRK and the Bowman's layer is already ablated, the soakage of riboflavin is faster into the corneal stroma. So we need not soak the cornea for longer duration. So even 10 minutes and 20 minutes of soakage times have shown good results. What about the fluence or the duration or energy of UVA that we apply to such corneas? So various studies have uh, done various protocols. I mean, right from 3 milliwatts for 30 minutes, 3 milliwatts for 15 minutes, 30 for 3, 9 for 10. What we do in Drishti is 9 milliwatts for 10 minutes. So essentially what they are saying that accelerated protocol is also equally efficacious. So we need not do it for the 30 minutes, which was done in the original Athens protocol. There are plenty of studies which show that accelerated protocol is also equally efficacious. Also, one study has shown that having the energy, I mean, even if you use 2.7 joules of energy, they have still gotten good results. So if a surgeon is skeptical about the risk to endothelium, because it is an already thin cornea, they can opt for this protocol. So one interesting study by Dr. Rohit Shetty et al. They have added another layer of complexity to this treatment by doing the Q value adjustment as a part of the refractive procedure of PRK in such eyes. So they have said that the Q value adjustment depends on the location of the cone. So in central cone, which they have defined as in which more than 50% of the cone is within the 3 mm central zone, preoperatively such eyes have a very high negative Q value. And in pre-op refraction, if we see the corneal myopia is very high. So there are two solutions to address this as a refractive procedure. The first one being that we reduce the Q to a less negative value by at least 20 to 30%. This manipulation of the Q value as a refractive procedure in eyes of central cone is preferred when the cornea is relatively thinner and there is a higher refractive correction. If that is not the case, if if the pachymetry is acceptable and the refractive correction is low, they straight away apply a partial refractive correction in cases of central cones. In cases of decentered cones, which they have defined as the cone which lies more than 50% outside the central 3 mm, preoperatively they have noted that these corneas have a less negative Q or even a positive Q value, and the pre-op refraction in such eyes they have noted to have lower corneal myopia as compared to the counterparts of central cones. So again, in the refractive part of this procedure, we have two solutions. The first solution being that the Q value can be changed to 0 preoperatively to prevent too much overshoot of the Q post-operatively. So we can adjust the Q value to 0, or the second solution is that if the refractive correction is performed, then the Q value can be left unchanged. So depending on where the cone lies, Dr. Shetty et al. Have proposed that we can do a Q value adjustment as a part of the refractive procedure.
So which protocol will you use for the ablation? Will you use a custom Q or topo guided in this kind of study?
Sir, they have mentioned that only in central cones we will manipulate the Q. Otherwise, they have said that manipulating the refraction itself is a better idea.
Mm. No, no, but because see, even in the second case in the decentered cone, they are saying that you can make the Q to be 0.
Mhm.
Okay, can be
Sir,
changed to 0 pre-operatively.
can
So
we
they can
adjust
change it to
the
0 and then
Q value in topo
yes,
guided PRK as well?
that was my next question. That's what I was going to ask you. That can you adjust the Q value in topo guided treatments? That was exactly my question.
Yeah, I'll find
In
out for
fact, I
you.
don't remember that we have done it ever, but we must check it out. I don't know. Dr. Ruchika might know this, whether we have an option to change the Q value on topo guided PRK.
Sir, I don't think we can adjust the queue on Topo Guided.
Mm, that's what I was thinking. But anyway, we
Also,
should
I
check.
was wondering that, I mean, in such highly aberrated eyes, is changing the queue really going to make a difference?
So I think in the upper category, yes, because there the Q value is very highly negative. So I think it might just help a little bit. So no doubt, because these are those eyes which have like central cones, very high myopia, and they're more of a spherical thing because of the high like hyperprolate cornea, and they're just trying to make it less prolate. So I think it might just help in improving the quality of vision. But I'm not sure. You should look up this study and find out whether they are, because it says at the bottom topography guided custom ablation. But if it
Yes,
is
sir.
topography guided, they are obviously using the EX500. And if they're using that and they're customizing Q, there must be an option. So we should look it up.
Yes, sir. Yes, sir. Yes, sir.
Also, I wanted to ask you here, Pranav, you mentioned that the Cretan protocol is doing PTK. Okay.
Yes.
So that means the Cretan, and I understood your point about the Cretan protocol basically trying to flatten the cone a little bit. So what epithelium thickness would you feel like for PTK? How much would you want to ablate? Have they spoken about how many microns they'll ablate, and whether they are doing epithelium mapping before doing that? Are they using the thinnest epithelium or they're using the thickest epithelium in the ablation for the PTK mode? For
Yes,
example,
sir.
the epithelium thickness might be like 30 microns, 35
Yes,
microns.
sir.
Whereas in the periphery where there is hyperplasia, it might be actually 60 microns.
Yes, sir.
What will you
So,
feed into your PTK mode?
yes, sir. So in the studies, they have mentioned that in keratoconus, they are not able to get accurate epithelium thickness maps. So in one study, they have arbitrarily decided to ablate 40 microns, and in another study, they have arbitrarily ablated 50 microns.
Okay, okay. Okay. So basically, Cretan protocol is not going to be done for topography guided, like trans PR, I mean,
No,
topography
sir.
guided treatments.
No,
Cretan
sir.
protocol is just PTK, standard PTK,
Yes,
right?
sir.
Not
Sir,
streamlined.
yes, sir. So PTK followed by Topo PRK followed by CXL is Cretan plus protocol.
Right.
If we
So
remove the
creatine is
PRK
basically
part,
just doing a PTK, and
yes,
then a creatine plus is basically doing a PRK. And then I'm only worried that if we did a creatine plus, we may end up ablating the cone more than what we need, because first of all, your PTK would have already flattened the cone a little bit by ablating it by 10, 5, 10 microns more than the periphery. Okay. And then you did the further topo guided treatment, which assumes that your cone was as if it was on the virgin cornea. So you might
yes,
get over ablation at the apex than what you intended. That's my thought.
yes, sir.
What do you think? So read up about this, that whether Cretan Plus they make any adjustments for the ablation which is happening on the cone, because where there you are already first ablating the cone a little bit by 5-10 microns and making it flatter, and then you're further going to flatten the cone, the apex, by doing the topo guided treatment as well. ठीक
Yes,
है
sir.
ना? So
So
let's
most of
read up
the
about it. And
most of the latest
mm,
studies which have been published, and I mean, Dr. Kaimionis and Canalopoulos, they have like published at least 10 to 15 papers, I think, on the same data set. Every year they have published
mm,
new paper on the same data set in different journals with essentially the
mm,
same outcomes. But 1 year follow-up, 3 months follow-up that way. But most of the studies, I mean, protocols which have come after the original Athens protocol, all of them have shifted to trans PRK, I mean, excimer based epithelium removal followed by trans PRK. So overwhelmingly, most of the studies are doing by default cretan protocol, cretan plus protocol, although they are
no,
not
no, I understand
labeled
that they're
it
doing
as
it, but have
cretan
they
plus.
discussed this point?
No, no, no.
No, I understand, but we should see the discussion part. Are they talking about this fact, and what they are doing? They might be doing something to kind of cope with it. So just read up more in more detail about what
Yes,
they
sir.
discuss about these things. I'm sure
Got
that
it.
some of the studies might be discussing this point. Okay,
Yes, sir. Yes, sir. So what were the
that's good.
outcomes of the studies? So in the immediate post-op period, only CXL patients versus Topo PRK plus CXL patients, both of them had similar levels of pain and they had similar rates of epithelialization. With regards to efficacy of the refractive correction, all studies have shown significant improvement in the uncorrected and the spectacle corrected visual acuity, spherical error, and astigmatism. Few studies have also shown a significant reduction in higher order aberrations. There is a regularization of the K values, improvement in the keratoconus indices like index of surface variation and height decentration, and reduction of aberrations. So a few studies have also compared the visual rehabilitation, and they have found that the visual rehabilitation was superior to those patients who have undergone only CXL. But in such studies, they have not been able to match the data. So they have done only CXL in patients who had really steep corneas and very poor corneal thickness. Whereas in the topo guided PRK plus CXL data set, in those studies, they have included only patients who are mild to moderate keratoconus and having adequate corneal thickness. So that is one confounder in these studies. And as far as stability, the long-term stability up to 3 years in multiple studies, they have shown that the K values and the pachymetry have remained overwhelmingly stable. So one point that they have also mentioned is that the cornea appears to rebound by gradually thickening up to 3 years postoperatively. And they have mentioned that the CXL alone results not just in corneal reshaping, but also in increase in the stromal density and refractive index, both possibly influencing the reported thickness by Scheimpflug device. Therefore, the true corneal thickness differences may not be accurately explored by Scheimpflug imaging due to the principle of Scheimpflug imaging, which is it operates on densitometry and which has been the well-known clinical experience with abnormally dense corneas. So they have mentioned that even though we are noting a gradual thickening of the cornea up to 3 years post-operatively, it can be fallacious because of the increased density of the cornea and the imaging principle of Scheimpflug, which is based on this densitometry. So it can be a fallacious finding as well.
OCT will be more useful anyway, because Scheimpflug is not great for non-virgin corneas.
Yes, sir. Sir, I'm forwarding another link. This class is ending in 1 minute. I'm sending another link
Okay.
on the group.
So in fact, nowadays we have a paid subscription for Zoom as well. You can ask Kamal for the login password and everything, and we can start using that for the class because there the class will not finish.
Yes, sir, sure, sir. So coming to Bharat Protocol, there is another protocol which is known as Bharat Protocol, in which they have done topo guided excimer laser ablation using accelerated high fluence cross-linking in keratoconus patients. So coming to Bharat Protocol, in which they have used a Nidex CXL machine, which is which has a customized aspheric treatment zone and final fit software. So the only distinguishing part in their protocol is that they are using, instead of wavelight, they are using NIDEC instruments from the diagnosis to the planning to the treatment. So this is a snapshot of what the treatment page looks like on NIDEC. So we see the pre-op topo and the targeted topography, and then it gets divided into the spherical ablation, cylindrical ablation, and irregular ablation. So otherwise, rest of the things are the same. Only the platform is different, and the results are also similar. So coming on to the debate of whether we should do it in a sequential manner or a simultaneous manner. Initially, some studies have shown that if you do a CXL first and later on 6 months or 1 year later, you can do a PRK. And most of the studies nowadays are showing simultaneous. So why is that? So a comparison study done by Canelopoulos et al. In this, they have mentioned that the simultaneous group has performed superiorly with regards to the visual acuity, spherical equivalent reduction, K reduction, corneal haze score at final follow-ups, and no eye lost lines of uncorrected or best spectacle corrected visual acuity as compared to the sequential group. So the stability and efficacy of simultaneous groups was much better as per their study. So there are a few reasons why people are preferring simultaneous procedure over the sequential one. One of them being that the combination reduces the patient's time away from work, because as we know, once we debride the epithelium and do the procedure, the patient is going to have a lot of pain, burning, watering, irritation for the next 2 weeks or 10 days. So that is going to reduce. More importantly, for us as doctors, uh, what matters is that performing both the procedures at the same time with a topo guided PRK first, it has appeared to minimize the potential superficial stromal scarring which results from PRK. Because as we know that PRK activates keratocytes into fibroblasts, which causes more haze. But to counteract that, we have CXL, which kills keratocytes up to 300 microns depth. Hence, a CXL post the PRK neutralizes the risk of haze to an extent. Another important point to note is that when the topo guided PRK is performed after the CXL procedure, essentially some of the cross-linked anterior cornea is removed, which is counterintuitive to remove the cross-linked tissue with topo guided PRK at a later time, as we are potentially removing a beneficial layer of the stiffer cross-linked cornea, which helps maintain the normalized corneal shape. So if we do CXL and we wait for 6 months and then do PRK, we are essentially removing the benefits of the CXL procedure that we had gotten. So nowadays, nobody is doing sequential procedures. All of them have shifted to simultaneous same sitting procedures. What about the haze? So Kaimionis et al. Have done a study in which they have found that in 50% of the patients, a posterior lineal stromal haze was visible on slit lamp, and they have said that this posterior haze gradually moves anteriorly and becomes less dense during the follow-up period. They have said that this finding could be attributed to the interaction between CXL and photoablation, which can result in keratocyte activation, and photoablation in combination with CXL may have induced keratocyte activation, causing a posterior stromal hyperreflectance formation. And this hyperreflective structure could also be associated with increased collagen deposition, collagen disorganization, and excessive production of extracellular material from the activated keratocytes. So, according to this study, if we recollect our discussion on the use of mitomycin C after the PRK, So according to this study, maybe using MMC after the PRK might be a good idea. But there are few studies which have proposed that mitomycin C should not be used, and this study can point towards the potential use of mitomycin C as well. What about the safety of endothelium in such procedures? Why should we worry about it? Because there is a significantly deeper effect of the CXL treatment in the eyes treated with the combined procedure in comparison with those treated with CXL alone. So the effect of this combined procedure on corneal keratocytes was most prominent and long lasting than the effect only in the CXL procedure. These differences can be attributed to a more potent effect of the CXL after the Bowman layer has been ablated, and the endothelial cell density was not affected by either procedure, demonstrating that when safety precautions are taken, that is a minimal stromal thickness before CXL of 400 mm, 400 microns, both the procedures are safe for the endothelium. So, which is to say that even if we are doing CXL on an ablated cornea, the endothelium does not get affected. So what are my takeaway points from this class? So which patients to include? Patients who have progressive keratoconus, who have a mild to moderate keratoconus, who have contact lens intolerance and poor spectacle corrected visual acuity with an adequate corneal thickness, which is of at least 400 microns post PRK. We should use the PTK mode for epithelium removal and do the topo guided PRK with or without refractive correction and or Q value adjustment. This topo guided PRK, we have capped it at only up to 50 microns depth. The use of MMC post PRK is still debatable. Uh, the order of CXL should be done immediately. I mean, it should be a simultaneous procedure. For the CXL, we can use the isotonic or a hypotonic riboflavin. Soakage time 10 to 20 minutes is enough. I have by mistake I have written 30 minutes. 10 to 20 minutes soakage time is enough. And the we can use the CXL accelerated protocol, which is 9 milliwatts per centimeter square for 10 minutes. So coming to what data we have in Drishti in-house, we have 13 eyes which we have done, and we do have up to 3 visits of each patient. That is to say, like 3 months, 1 year, 2 year, or 6 month visits. We do have a 3 visit follow-up up to 1 year. So the mean age of our patients was around 22 years. We have treated 8 males and 5 females. The pre-op versus post-op uncorrected and the best corrected visual acuity is significantly better post-operatively, and the improvement in the vision is statistically significant. And the average pre-op pachymetry in our patients was 483 microns, and the average post-op pachymetry in our patients was around 450 microns. So essentially, we have done around 33 microns treatment on an average in the eyes. So we are planning on extending the data set to further follow-up visits and also include other data sets like keratoconus indices and K values and I mean, K values we have already included, but other few indices we are going to add as well as the long-term follow-up. So that is the plan, sir.
So, Pranav, you should have also taken the treatment protocols, the PDF of the treatment itself, and seen what was the maximum depth ablated and the minimum depth ablated on the topo guided planning. Hmm?
Yes, sir.
Because what you're showing up as 30 microns only seems to be incorrect, actually. We usually do go up to 50 microns, on the cone or in the superior area where you mentioned.
I will take out the PDFs of these patients, sir.
Right. That would give us more information. Huh?
Yes, sir.
And also, did we encounter any complications?
Sir, I mean, this is just the preliminary data collection that we have done. We are going to add, I mean, complications like haze or melt or delayed epithelialization, things like that, or loss of lines in
So we
vision.
did experience, while our overall experience is very good, but we did experience certain things. So I'll be interested in knowing what all we experienced.
Yes, sir. So that is the end of my
And yes, our
presentation.
visual results were very gratifying. I mean, most of our patients improved drastically, actually. And we should see now, the thing is that what we have understood is that initially in the first few months, the treatment results maybe or improvements may be quite significant, and patients may visually gain a lot, but it's not long lasting. So, some of the studies have actually shown that over time, the patients may not do as well as they do in the beginning.
Yes, sir.
Also, the risk of haze and what we can do to minimize haze and what is the distribution of the haze.
Hmm. Yes, sir. So that debate about MMC, that is still unclear whether we should use it, because in our protocol we have used it.
Right. Mm. I think we are using it and we've been fairly happy about it. We feel
Hmm.
that it should be used, according to me.
Ma'am, any inputs, ma'am? Mr. Biman has also joined, sir, so
So
maybe he can also have a few inputs. Yes, ma'am.
we
Ma'am, you
did
were saying.
experience, we had significant haze in about, I think, two patients, I think. And these were the patients in whom we had attempted, apart from regularization, we had attempted a small correction of the astigmatism as well. So we had basically done a much higher ablation, like maybe touching up to say 60 microns or something. We had done a little more. This was just an like we had attempted in one or two patients, and fortunately the haze was not in the visual axis. It was somewhere in the mid periphery, but there was significant haze. And over time, the haze has reduced, and I mean, further follow up is awaited. But these are patients who we've already followed up for close to a year. So their haze has reduced over time. But yeah, this was the only significant complication that we encountered. Apart from, yeah, I think maybe one or patients who didn't show any visual improvement. These were patients who, apart from keratoconus, were also high myopes. So, they didn't have much of a visual improvement when it came to especially the uncorrected. So, yeah, we've not had melt or delayed epithelial healing in any of our patients.
Absolutely right. In fact, the one patient where we did get significant haze, there we had actually ablated much of the astigmatism as well. After that, we
Sir, your voice is not audible, sir. Hello.
Yes, Pranav, I think I got disconnected for a while.
Yes, sir. So you were saying
So I
about
think
haze, sir.
yeah, so here's जो मैम ने बताया वो exactly correct है. That's exactly what my thoughts are also, and that's I mean I have nothing more to add over there. So that's about what I felt, that the haze is definitely something we should watch out for, and we should also be watching out for any regression or something of the effect that we achieved. So I think our long-term studies of all our patients might be a good idea. Let's kind of, if those some of our patients have not come for follow-up, let's try to call them up and try to call them back for a repeat evaluation and maybe do a specular and pentacam and an OCT as well to understand how they are doing. So that we can assess how the long term results are. It'll be worth publishing actually, because 39 is not bad, and maybe we should look for more patients who might benefit from this.
Yes, sir.
And I think what is of value is some of our patients have had a follow up almost like more than 1.5, 2 years now, because we started, I think, 2 years back. So that will also give us an idea whether these patients are maintaining the vision that they got initially. Also, one more thing that I wanted to add was you mentioned, epithelial removal by PRK or PTK. So we don't follow either. We do a like a brush removal because of the fact that the epithelium is not regular in these eyes. So the same thought that goes behind using PTK, but instead of using PTK, we go with a brush removal because there is no fixed epithelium or regular epithelium in keratoconic eyes. So we do a a brush removal of the epithelium and then follow it.
Yes, Dr. Ruchika, in fact, but I feel that maybe, it's worth thinking about, doing a PTK and then topo-guided ablation as in the Cretan Plus protocol. Once we are clear about what they have kind of discussed about the fact that the cone will receive extra ablation than what was planned on the topo-guided thing.
Right.
So this is my thought. Yeah. Anything else? I mean, I think we should study our data in more detail, Pranav and Shruti, because we should study our own data is quite elaborate, 13 eyes and lots to see, and how each of our patients did might be worth discussing.
Yes, sir. Yes, sir.
Okay. And let's do a journal club and pick up like 2-3 studies. Maybe this Shruti can do. You can pick out the 2-3 articles which Pranav says, like the Cretan Plus, and some of the like new studies which are benchmark studies. You can show to Dr. Ruchika, and then we can do a small journal club and discuss the 2-3 latest studies on topo guided PRK CXL extra, so that will help us prepare for our own study.
Yes,
Yes,
sir.
sir. Sure. Also,
Okay.
Pranav, I wanted to ask the patients that we have done at Drishti, they all were like having central cone, or there were inferior cones as well?
About that
This is only
data,
for the central cone.
no, no, no.
Okay,
Most of,
actually I can answer this one.
Okay.
yes, please.
So yeah, most of the cones are actually inferior temporal.
Okay.
I have seen actually only one patient who is actually like a central cone, near to central cone, but most of those are actually inferior temporal. And regarding visual acuity, when I entering the data, I remember one of the patient whose vision has actually improved from 618 to 66. So what I actually emphasize like that, if someone actually vision is only 6 by 36 or 6 by 24, and followed by like topo guided CXL, vision is improving to 2 lines or 3 lines, that actually improve their day-to-day activities. So I have deal actually a couple of patients and they are very happy with actually the output, the result. So as Dr. Pranav already said earlier also, like that most of the Indians, they have actually inferior temporal cone, whatever I have most of the time I
Okay.
have observed.
Okay. Okay.
But their involvement actually they are also in 3 mm, 5 mm, and 7 mm zone. If you see the pentacam,
Mm-hmm.
the
Hmm.
involvement actually like that, like in keratoconus, still like a 3 mm or even 5 mm or even 7 mm or 9 mm zone also. So while entering the data, I have actually entered the data also, like what the extent of this keratoconus.
Okay. Okay.
So, yeah, actually, practically, you'll find that very few patients in our pool or, the patients that we see on a day-to-day basis of keratoconus, very few will actually have central cones. Most of them have inferotemporal or inferior cones. So, in fact, when you compare the pentacams, when you study our topo-guided results, you'll see that topo-guided treatment actually sort of centralizes the cone. by having
Okay.
that effect of, flattening the steep areas and indirectly steepening the flat areas, it will
Okay.
sort of regularize and centralize the cone. So that is one reason why the vision improves in these patients.
Okay.
So, Pranav, are we done?
Yes, ma'am. Yes, ma'am. My presentation is done, ma'am.
So I think with sir's permission, like, do you want to wind
Hello?
up or?
Hello?
Yes, sir.
Hello?
Yes, sir, we can hear you.
Okay, okay. So, Dr. Ruchika, the one last thought before we wind up. I was thinking that that set me thinking what Pranav was saying that when we do CXLs, we are not planning a topo guided treatment at all, and we don't intend doing it. Should we do epithelium removal instead of doing it the manual way that we are doing it? Should we do the PTK mode, and that might help in that both the ways that it does cause that little bit of apical flattening, and in a way works like a topo guided treatment without actually doing it, and then do the CXL. So it would be something like a CXL extra or something, or whatever you are calling it as a Cretan protocol. What are your thoughts on that? And moments will get ablated a little bit, and we might have better penetration of the dye. And I don't know whether the CXL effect will be a little better, and maybe the visual improvement may be marginally better as well.
It is worth trying in a few
Suppose
patients,
we
sir.
So what we could do is we could feed like something like maybe 45 microns, whatever is the thickness of the epithelium in the apex, we could feed in like maybe 5 to 10 microns more than that, so that we get about ten microns of flattening of the cone. Okay. And
Hmm.
also the epithelium removal in the periphery. So basically, we would be looking to remove the epithelium. So suppose our thinnest epithelium is like 35, 40, and the thickest is 50. We could feed 50 so that all the epithelium goes and a little bit of the apex goes, and then cross-link it. So that we could create a new entity of like not topo-guided CXL, PRK CXL, but just CXL extra or something like that. You know and PTK CXL or something like that, and
Hmm.
see how those patients are faring.
All right. So only
And
the only practical issue is 80 to 90% of our patients are Ayushman, and now everyone wants to
acha.
get cross-linking through Ayushman. There are
So we can tell them
barely
that
any.
this is not available through Ayushman. We'll tell them that if you want a proper treatment, then this is the proper treatment. Through Ayushman, you are not getting any kind of extra benefit. You're only getting a basic kind of a cross-linking, which is only going to stabilize your disease. Whereas what we want to do is to maybe improve your quality of vision a little bit by doing that. I mean, this is somewhere in between topo-guided CXL and CXL, right? So it is worth kind of mentioning that this is a and charge a little bit upfront for it, maybe not significant, but because the PTK part does not cost us much more, the streamlight part costs us much more. So if we are just doing a PTK on the examer day itself, and we are marking up the price of the CXL by maybe 10,000 rupees, that should be enough to offset our costs.
Hmm.
Chalo, let's add in, but this Ayushman has really killed everything. I mean, now Ayushman, even people who can afford anything are now wanting to do Ayushman treatment in our state. That's a big problem.
Hmm. And
So I don't.
fortunately, to be, all said and done, Ayushman still gives a good cover for cross linking. I don't know how and why, but it does. It's way more than any surgical, even for transplants, they give like what, 3, 4, 5,000, but CXL still has a decent cover in Ayushman.
Right, right. Yeah. So we are not against doing Ayushman CXLs. But theek hai. So if
Right.
anybody, only problem with Ayushman is that they don't allow any kind of additional payment. They don't charge even 1 rupee beyond what Ayushman pays. Otherwise, you are in a soup.
Mm.
So you cannot up sell Ayushman treatments. That's the only limitation. Stuck with doing what we are doing. We can't do anything beyond it. But I think what we could do is for for a few patients. to just do a study on this. We don't necessarily have to charge anything extra. We just make them pay full upfront for CXL and do 5-6 cases and see without, even if they are not paying extra, we just absorb the cost and just see for the sake of studying the results. I think we should do that. ठीक है ना? So next time you have any CXLs planned, let's just do it. Even if they don't pay extra, we'll still go ahead with the PTK mode and do the CXL at the LASIK center itself. And with a shorter soak time and with the reward protocol.
Right.
ठीक है ना? So let's do like patients we can do without charging anything extra for it. But those who are willing to pay, we just charge 10,000 extra for it. That's all. ठीक है ना? So करके देख लेते हैं. ठीक है?
ठीक.
Chalo ji. So I think I'll have to log off. Actually, I'm already driving. I had a meeting. So if you guys want to continue, but I'll have to log out now.
Thank you, sir.
Thank you. Thank you. Good night.
Good night, sir.
Okay, Pranav, thanks.
Okay, thank you, ma'am. Thank you.
Thanks.
Thank you, ma'am.